We are live.
Good evening and very warm welcome to everybody. Today we have with us the very young and dynamic Dr. Pallavi Singh. She's an oculoplastic and squint surgeon. She's completed her MBBS at Maulana Azad Medical College, New Delhi, her MS Ophthalmology from AIMS, New Delhi. She's done a fellowship in orbit and oculofacial plastic surgery at UCLA Stein Eye Institute under Dr. Robert Goldberg, and she's trained with some of the top Beverly Hills plastic surgeons. Currently, she runs her own prolific practice at Lucknow and Ahmedabad. She's the assistant editor for the Indian Journal of Ophthalmology. She has over 30 publications and has authored multiple book chapters. She's been an invited speaker and awardee of various research honors and has been the former best senior resident at AIMS. She's presented at several national and international conferences, and we are honored to have you with us today, ma'am. Welcome and over to you.
Thank you so much for that extremely kind introduction, Dr. Megha. So we're just going to get right into it. Today we're going to be... Is my screen visible?
Yes, ma'am.
All right, perfect. So today we're going to be talking about the approach to long cases in oculoplastics and orbit. This is in fact one of the most common cases that we get for our exams, and oftentimes, students are a bit confused about how to approach them because we might not have as much exposure to oculoplastics in general. I'm going to try and simplify this a bit, and hopefully you'll have a clearer idea about how to go about things at the end of this presentation. So we're going to be discussing four major topics here: proptosis, ptosis, late tumors, and the contracted socket. These are some of the most commonly given long cases in the exams, and we're going to try and see how to approach them. Now, what we have to understand that when we talk about approaching these long cases, the idea for the student in these cases is to make the examiner know that, I know how to examine these cases. I know how to get to a differential diagnosis. You don't need to give them the exact diagnosis, but you need them to know that you have an organized way of thinking. And I think we're going to go through that for each of these cases. And hopefully by the end of it, things will be more clear. So we're going to talk about history, examination, in all of these cases, any specific tests that we're doing. And then, of course, on the basis of that, you would want to have your differential diagnosis. And at the end, we'd also talk about some ancillary tests for each of these cases that you'd like to do. All right, so let's talk about proptosis. What is proptosis? Proptosis is when the eyeball is protruding more than 22 millimeters beyond the orbital rim, or if there is an asymmetry of more than 2 millimeters between both the eyes. So let's talk about what are the history taking points that we have to be sort of cognizant of whenever we are presented with a case of proptosis. So obviously you want to ask them whether it's just one eye or if it's both eyes. Along with that, if they've had any loss of vision, sometimes if the mass is compressing the optic nerve, there might be a loss of vision. If they have any restriction of motility, which might be causing any double vision, that's one of the things you want to ask them for. Any redness, pain, discharge, especially in cases which might be infective or any acute onset cases. So these are questions that you must ask in any case that is coming to you with proptosis. This is one way of letting the examiner know that these are the things I have thought of, and these are the things that I have ruled out. So they know that, yes, you're thinking of all of these things and you've gone about in a systematic manner. Again, we're talking about the history of presenting illness. You want to know what is the age of onset. If they're older patients, it might be something malignant, or if it's younger, it might be some sort of vascular malformation. What was the nature of onset? Was it sudden? Was it gradual? How it was progressing? If there was any pain, what was the laterality of the lesion? If it's bilateral, very common disease that occurs in the Indian population is thyroid eye disease. And if there's any pulsations that you feel, that might be indicative of an arteriovenous malformation. And of course, you want to always, in all of these cases, have a detailed, systemic history. Ask them about any history of malignancy, any other body part, thyroid, disorder, any trauma, or any other periocular tumors that they might have had. So there are a couple of slides here in this presentation that I would encourage you to take screenshots of, because all of these points that we're discussing during history taking and examination, the differential diagnosis for all of these you would find in these slides. So if you look at the age of onset, you have different, different causes of proptosis depending on the age. So you have different causes in newborn children, in newborns, in children, and young adults. So you can go ahead and take a screenshot of this. And then as in when you ask these questions, you know what your differential diagnosis is going to be. Again, when we talked about onset, if you have a catastrophic, which means like within minutes to hours, or acute, a subacute or chronic onset of these diseases, what are the possible differential diagnoses that might be? You can go ahead and take a screenshot of this. Now, coming to examination. So again, proceeding in a systematic manner. First of all, of course, you would like to check the visual acuity of the patient. You would like to see whether the vision is okay or if the vision's reduced. Moving on to the eyeball, when we move on to when we think so we'll go in a systematic manner. We'll go about with inspection, palpation, auscultation, and all of those things, just how we go about examination in a general surgical case. All right. So when you look at the protrusion of the eye, there are two ways of seeing it. There's the worm's view, where you look at the patient from down up, and there's the Navziger's view, where you look at the patient from up to down. So you can see any protrusion of the eyeball by using these two methods. Again, the other thing that you want to see, whether the proptosis, which is the protrusion of the eye, whether it's axial, which means whether it's in the line of the eyeball, where the eyeball would be moving straight ahead, or if it's abaxial, which means the position of the eyeball is it's displaced from what the central axis should be. So if you can see the case on the right, there is an inferior displacement of the eyeball. So you know that the mass is somewhere superior. Again, one of the screenshotable slides, where if you have a abaxial proptosis, depending on where the mass is located, you'll have different causes. So again, this is something you need to know in general. If it's a superior mass, there's a likelihood that it might be a mucocele, like the patient in the slide before had a mucocele. It might be a neurofibroma. If it's a lateral mass, it might, in the corner, in the superior lateral quadrant, it might be a dermoid cyst, a lacrimal cyst, or a, sphenoid wing meningioma. So after examining the protrusion of the eyelid, of the eyeball, the other things you have to look at, specifically in the case of a patient with proptosis, is you have to look at eyelids. If there is associated thyroid eye disease, you might have retraction, or if there's neurofibromatosis, you might have an S-shaped eyelid. You have to look at any periorbital inflammation in cases of infective, pathologies. In cases of mucormycosis, you might have some black colored discharge in the nose or the roof of the mouth, so you have to look at that. And in cases of vascular malformations, it's always good to do a Valsalva. You can see a change in the size of the proptosis with that. And of course, if the proptosis is a lot, then you'll also have lag of thalamus. So these are the things that we should look at in these cases. Now, moving on to palpation from inspection. One of the common things that we like to do is retropulsion. Retropulsion is essentially just using your thumb to push gently against the eyeball. And if you feel some sort of resistance as compared to the normal side, you know that there's a mass behind the eyeball, which is causing that, that resistance to the push that you're doing. So that's called retropulsion. Of course, if there's some sort of arteriovenous malformation, when you put your finger on the eyeball, you will feel a sort of pulsation or an orbital thrill. In cases of malignancies, in general, you always want to check for lymph nodes, because in cases of malignancies, you might find that there are lymph nodes that are positive. You want to look at the preauricular, at the submandibular, at the cervical lymph nodes. These three lymph areas should really be checked for lymph nodes. Again, it's important to palpate bony margins, especially in cases of malignant tumors. There might be, some damage to the bony structures there. So you might feel like the bony margins are sharp, or it's scalloped out, like in cases of adenoid cystic carcinomas, you might find that. If the mass is soft, if there is a venous malformation, sometimes the mass may be reducible, which means is that if you're pushing the eyeball, you might feel that the mass is shrinking in size. So that's also one thing to look at. And of course, one very important thing that you have to look for is periocular sensations, which essentially means that you will touch the patient's skin, around the eyes on both the sides, and, compare it. Because a lot of cases, especially in cases of adenoid cystic carcinomas, there is perineural involvement, and the nerves around the eye get involved. And so you might have some loss of sensations there. So examiners really like to, when you're getting everything right, this is one of the things they like to ask: have you looked at sensations? And if you say that you have, they would be happy, before them asking, if you tell them that you've looked for sensations, they know that, you know, you're looking for all of these things. Again, auscultation is an extension of palpation. If there is a very obvious arteriovenous malformation, you might feel a pulsation on auscultating it. Typically, we don't do it as much, but yeah, sometimes if you have someone very enthusiastic, you can always have a stethoscope around and sort of do that. Transillumination helps to identify cystic structures. You know, if there's an obvious orbital mass, and you can place like your a pen torch on one end, and if you see the light transmitting through the skin, you know that it's a cystic structure. The other things that you have to look at in a case of proptosis is the conjunctiva, if there's any chemosis, any congestion, which is very typical in cases of thyroid eye disease. If you have any lymphatic vessels, very common in cases of lymphangioma. You have to look at the cornea for any exposure keratopathy. In the iris, in cases of neurofibromatosis, you might find Lish nodules. Again, very important to look at the pupil, because anything which is compressing the optic nerve will cause, it can cause an afferent pupillary defect. The other thing that I haven't mentioned here, it's also a good idea to look at the color vision, because color vision is one of the first things that gets affected whenever your optic nerve is getting compressed. So, and also if you want extra points, so that's one of the good things to look at. Intraocular pressure is raised in cases wherever you have an orbital mass, specifically in thyroid eye disease, and in those cases, when you ask the patient to look up, the intraocular pressure might increase more, because in most of these cases, the inferior rectus is hypertrophied. So any movement of the eyeball, is causing more resistance and increasing the intraocular pressure. Again, very important to do a fundus examination, because in cases of huge masses, you might have choroidal folds, you might have optic atrophy in long-standing masses, or papilledema. Again, this is an article from DOS Times, which lists all of the signs that you see in thyroid eye disease. I have 2 slides where all of the named signs are given. This is good. Sometimes examiners like to ask you this, and it's a good ready reckoner to have with you, just to look at signs of thyroid eye disease. So this is slide number 1, and this is slide number 2. You can take a screenshot of this as well. This gives you most of the name signs that we see in thyroid eye disease. One of the most important parts of examination in cases of proptosis is performing a Hertel's exophthalmometry. I think going into how Hertel's is exactly done is out of the scope of this lecture, but make sure that you have done a Hertel's examination and you have on paper objectively how many millimeters of proptosis the patient has. Other options of doing exophthalmometry include the Ludes and the Knockley's exophthalmometers. They're not usually available in in our setups, but Hertel's is commonly available, and of course you need to have your Worms and Navziger's view. So these are the 2 things. These are the things that you need to know. Once you have done all of this, once you have done your history, once you've done your examination, you should be able to tell how long the mass has been there for, whether the progression is very fast or whether it's chronic, which quadrant the mass is in, and whether it's cystic or solid, whether it is malignant or benign, because you can also get to know, depending on the chronicity, depending on whether there is any lymph node involvement or any, periocular nerve involvement. So these things will give you a clue about whether the mass is benign or malignant. So with your history and examination, and in all of these cases, you should have a differential diagnosis. And now all of the slides that I had shown before, where you have differential diagnosis for different quadrants and different progression, you should have those things in mind. So you should have, by this time, a list of 5 or 6 things that might be in your differentials. Now the question comes, how do we confirm what our diagnosis is? So for these reasons, you perform these ancillary tests, which will help you to get to a definitive diagnosis. Now, what are the ancillary tests that we can do in these cases? Of course, back in the day, X-ray orbit was done. I feel still some of the, examiners like to hear that X-ray orbit is one of the things that we can do, because it's easily available at all centers. And again, this is one of the things that you can mention. Ultrasonography, more important than X-ray, because again, widely available, and it can tell you whether, at least it can tell you about the nature of the lesion. It can tell you whether it's cystic or solid, what quadrant it's in. So it can give you a rough idea of, some of the characteristics of your lesion. And once you've done these things, and once if you're at a tertiary care center again, then the next thing to do is to either do a CT scan or an MRI scan. Now, the cases in which you will do a CT scan is when you want to know more about the bones or when you're taking the patient for surgery. So if anyone asks you for a diagnostic point of view for a better soft tissue delineation, MRI is a better option to know what the diagnosis is. But if you're if it seems like a bony lesion, like some sort of fibrous dysplasia, or if you're taking the patient up for surgery, then it's important to know what your bony margins are. CT scan would be more advisable in that case, but also MRIs are more expensive and not as widely available. So if your MRI is not available, I think a CT scan, especially contrast enhanced CT scan, is a good first step to get a good idea about what your lesion might be. Then again, if you're sure that if the patient that you have is a venolymphatic malformation of some sort, then doing a venography or an angiography of some sort is something, examiners are happy to hear that. And in terms of histopathology, of course, if you don't want to do anything super invasive, then an FNAC is the way to go, or you have incision and excision biopsies. So these are the tests that you want to be doing to confirm a case of proptosis. And then, of course, once you've reached this point, then you've reached the differential diagnosis. And then you'll have your viva will go on to, what particular treatments might be. You might move on to different types of orbitotomies. In cases of malignancies, you might move on to, whether chemo or radio, whatever the treatment is for these cases. And that will be specific to whatever lesion it is. But I think 90% of your viva is just this, the history, the examination, and the specific tests that you want to be doing, because examiners want to know whether if a patient, walks into your OPD with proptosis, will you be able to examine the patient, If you go out after your post-graduation, nobody is expecting you to treat these cases of proptosis, but people are expecting you to diagnose. So I think that's what most of our examination is, most of our exams are geared towards. All right, so whenever you make a diagnosis of proptosis, you want to mention the onset, you want to mention whether the proptosis is axial or abaxial, and if you have any associated features, like if there's any optic atrophy, if you have any eyelid retraction, any other case, any other features of thyroid eye disease. So moving on from proptosis, let's move on to ptosis. Again, one of the most common long cases that you get in your exams, because it's just so common. So in all likelihood, you might have some patient of ptosis walk into your hospital on the day of your exam. Again, when it comes to history, we want to know what the onset is, what the duration has been, whether it's congenital, whether it's acquired, if there's any variability, if there is any diurnal variation. If you know that there is a diurnal variation, you always have to have myasthenia in mind. And how severe the ptosis is, if it's mild or if it's severe enough that the activities of your daily living are affected. And of course, you also have to mention whether one eye is involved or both eyes are involved. Now, these having done the general history, you want to ask about specific things again, so your examiner knows that these are the things that you're thinking about. You have to ask about trauma, if there have been any previous eye surgeries, because that might also cause levator dehiscence and might cause ptosis. Any constant contact lens use, any history of eye allergies or eye rubbing. And then, of course, you have to ask for associated conditions, like whether the patient has any double vision, any jaw winking, any problems in eating, or, any worsening with tiredness. And of course, you also have to ask about any family history of blepharophimosis or ocular myopathies. So that completes our history taking for ptosis. Now, what are the things you have to look at when the patient comes to you for examination? We would obviously like to do a general examination, talking, the visual acuity, the pupil, the anterior and posterior segment. But specific to ptosis, what are the things that you're going to look at? You're going to see whether the patient has any head, any chin up posture, because when they have bilateral ptosis, in order to see a patient, would always have a bit of a chin up posture. And whenever you're presenting your case to the examiner, even if the patient does not have a chin up, if you tell the examiner that no chin up posture was noted, the examiner knows that you've looked at that. So it's always a good idea. Your negative history becomes more important than your positive history, because your examiner knows that yes, they have looked for these things. So be cognizant of these points and make sure you mention them. You can just write it down in one place. And if you have a ptosis case that comes up, you just check off like yes or no. And you know that the examiner will know that you've looked at all of these things. You obviously want to look at the bony structure if there is any facial asymmetry, especially in cases like blepharophimosis, BPES. The other thing you have to look at cases that might have apparent ptosis, but it's actually not ptosis, but it's enophthalmos, because if the eye is pushed back, that will give the look of an apparent ptosis. If the patient has any frontalis overaction, like in this case, and in cases of blepharochalasis, if the skin of the eyelid is very thin. So that's also one thing you have to look at. Again, very important when it comes to ptosis is looking at the extraocular movement. I cannot stress it enough, because if you have a simple case of ptosis, yes, your extraocular movements will be normal. But a lot of times, ptosis is associated with the third nerve palsy. So you will have limitation of movements according to the third nerve palsy, or you might have a monoocular elevation deficit. So it's very important to mention what the ocular movements are like. And like I said, your visual acuity is very important. This is one of the common questions. A lot of people tend to think that vision deprivation amblyopia is the most common cause of poor vision in ptosis, but it's not that. It's the most common cause is anisometropic amblyopia, because these patients tend to have a higher cylinder. So that's one of the questions that examiners like to ask. Anterior segment, especially important in cases of third nerve. If it's involving the pupil or in Horner syndrome, there's going to be an anisocoria. Posterior segment, it's important to look at that. For instance, in cases of Kern-Sire, where you might have some sort of retinal pigmentation. So again, because any outward manifestation of the eyelid might be associated with like 5 different things. So you have to be very meticulous in your history taking and examination, so the examiner knows that you know all of these conditions exist and you've ruled them out. Now, moving on to specific examination of the eyelid itself, you have to note the position of the eyelid crease, which is the faint line that forms when the patient is looking down. You have to measure how much it is, how much it measures, and you have to mention whether the patient has any lid lag or any lid droop. In cases of congenital ptosis, the patient will have a lid lag. In cases of acquired ptosis, the patients tend to have a lid droop. Whether on closing the eyes there is any lag of thalamus, what the Bell's phenomenon is like. That's very important, because when you're operating on these patients, you want them to have a good Bell's phenomenon. Again, and this is the grading of Bell's phenomenon, you can find it in most of the textbooks. If there is any associated eyelid retraction which is present, if there is any synkinesis, a lot of patients present to us with Marcus gun jaw winking. So always make sure that you're making them move their jaw. So you know that if there's any jaw winking, a lot of times Marcus gun is associated with monoocular elevation deficit. So be careful about looking at the extraocular movements in these cases. And of course, you have to be very careful and mention that you looked at the cornea, because if there's, especially in cases with pre-existing dry eyes, they would be poor candidates for ptosis surgery. These are some slides. I think we can quickly rush through them, but this is just documenting the specific things that you need to document during your ptosis examination, which is the margin reflex distance 1, the margin reflex distance 2, MRD3. This is when the eye is looking up, the margin to limbus. There's different, versions that the different findings that the examiners like to know. The palpebral fissure height, the margin crease distance, we talked about that. The tarsal platform show. And again, one of the most important things that you have to look at is the levator function. In this case, you block the frontalis and you measure with a scale how much the eyelid excursion is. That will tell you whether the levator function is poor or good or fair. In newborn babies, so sometimes, again, examiners like to ask questions So these are specific questions, specific tests that might be done. So in newborn babies, it's you cannot ask them to move their lid up and down. And if they present with congenital ptosis, one of the ways of understanding whether the levator function is good or not is everting the eyelid. If the eyelid reverts on its own, then it is good levator function. And if it doesn't, if it stays everted, then you know that the levator function is poor. This is called ELIF test. Cogan's lid twitch, another sign seen in ptosis associated with myasthenia. If you look at the child when she's looking up, the eye tends to flicker. It tends to overshoot a little bit. This is called the Cogan's lid switch, lid twitch. It is associated with myasthenia. The other thing you need to know is Herring's law. Um, Again, because of ptosis in one eye, there might be associated retraction in the other eye, which becomes normal once you correct the ptosis. So these are just ancillary things that you need to know. Again, in cases of myasthenia, it's important to do an ISPAC test, a Tensilin test to confirm myasthenia. So once you've done this whole examination, once you've done the history taking, you should have a diagnosis which tells you about whether the ptosis is simple or complicated. A ptosis is complicated if it is associated with a third nerve or a Marcus gun or a monoocular elevation deficit. You have to mention in your diagnosis how severe the ptosis is, whether it's congenital or acquired, and of course, if there's any other associated features. Once you've reached up to that point, then the discussion will move on to the management of ptosis, which again is beyond the scope of this discussion. But I think that's also one thing you need to really study carefully, because in cases of proptosis, I think getting to the diagnosis is the main crux. But in ptosis, because the history and examination is fairly quick, I think a lot of discussion also hinges on what the management is. So that's something you should look at. Now, moving on to lid tumors, again, we want to look at what the presenting complaint is. If there is a growth on the eyelid, you have to specifically ask if there was any ulceration, if there was any loss of lashes, any distortion of the eyelid, if there was any pigmentation, any other masses that they could feel. You want to know about the onset progression, if there are any other lumps anywhere. That's an important question. If there was any pain, any systemic features of metastasis, which would be weight loss or fevers, any lower back pain, just the general features that we ask about metastasis. The other very important part in history taking in these cases is any trying to figure out any trigger factor that might have caused these tumors. So we want to ask about ultraviolet exposure. We want to ask if if they are farmers, if there's any history of any ionizing radiation, if there's any history of HPV or any infection or any immunocompromised state like HIV, any genetic diseases like xeroderma pigmentosum, or if there was a history of recurrent chalazion, which is seen very commonly in cases of sebaceous cell carcinoma. When you do an examination, again, you want to describe the mass like how you describe a mass whenever we were doing our general surgery examination. So you want to describe the length and the breadth. You want to describe its position on the eyelid, on whether it's cystic or solid. Now, the important thing, if you see on the left, you know that the mass is benign because it's not causing any distortion of the lid margin. It is just sitting on the lid margin. There is no loss of lashes. There are no telangiectasias. Whereas if you see on the right side, you can, right away by looking at it, you know that it's a malignant mass. But why? It is distorting the tarsal architecture. The shape of the eyelid is lost. You can see small vessels on it, telangiectasias. You can see that there is loss of lashes. And of course, the history was also very acute onset. So it was in the last 6 months that this happened. So all of these things will help you to determine whether the tumor is a benign or a malignant tumor. In long cases, you usually get malignant tumors. One very important thing whenever you are given this case is to evert the conjunctiva. Even if you haven't done it, it's important to tell your examiner that you've everted the eyelid, because a lot of times the conjunctival involvement is very extensive. Like in this lady with a sebaceous cell, once we everted the eyelid, we realized that there was a huge tumor. So it's very important to evert the eyelid to look at the tarsal conjunctival spread. It's also important to look at the bulbar conjunctiva, because in cases of sebaceous cell carcinoma, you might have skip lesions. So, staining the conjunctiva with rose bengal or fluorescein or whatever, these are the things that you have to mention in your exam. Even in cases of OSSN, conjunctival involvement is what is main. So it's important to look at the conjunctiva. Then again, in large tumors or tumors which are encroaching on the sclera, it's important to look at what the integrity of the sclera and the globe is, at least make a mention about it. When we talk about ancillary testing in these cases, of course, we talked about the eyelid, we talked about checking for the lymph nodes. So you can either go ahead with an incision or an excision biopsy, depending on how big the lesion is. Other tests that we might do to check for lymph node spread is sentinel node biopsy. In cases of OSSN or any sort of conjunctival malignancy, and impression cytology is always helpful. So you need to know the names of these tests so the examiner knows that you know that these conditions exist. If it's a large tumor and you can do like a core biopsy or a fine needle aspiration. Again, if it's a big tumor like this one, it's important to have some sort of an orbital scan, either a CT or an MRI, to know how deep the orbital spread is. And sometimes you might have metastasis also in these cases. So it's helpful to have a PET scan. So these are the names of these tests that you should know, that you should be able to tell your examiner. Moving on to the last case, which is very commonly seen in our exams, is contracted socket. So a contracted socket is essentially when the socket of your eye does not have enough space to either house your prosthesis, or if it's an ophthalmic eye, which means if the eye is still present and it's not an anophthalmic socket, then the socket is contracted, which means that the eyelid is sticking to the eyeball. So there is no free movement of the eye. So a lot of these cases, most of these cases will present to you post-evisceration or post-enucleation. The complaints will be of an ill-fitting prosthesis, and those are the usual cases that we get for the exam. We don't usually get cases of ocular surface disease like SJS or OCP as much. It's mostly anophthalmic sockets, so we're going to mostly talk about that, but the principles are the same whenever you're examining any of these cases. So just keep these points in mind. So what are the presenting complaints of these patients? There is a poor cosmetic appearance. There is repeated extrusion of the prosthesis. Sometimes children present to us with, congenital anophthalmic sockets. So, there is shrinkage on that side. Again, the history of presenting illness, you have to ask at what age the onset was, what was the preceding surgery that was done, whether an implant was put in the eye or not, whether the eye was okay, and then the implant, then the prosthesis started extruding, or was it this way since the beginning? Very important to ask what the cause of, very important to determine what the cause of the contracted socket is. So it's important to get a good past history, whether there was any chemical or radiation injury, because these cases are notoriously more difficult to treat. Any case with any sort of radiation injury will have some level of bony contraction as well, which is more difficult to treat as compared to only, surface area contraction. So it's important to ask them whether there was any chemical injury, any history of radiation, if there was any cicatrizing disease like, SJS or OCP, if there has been any chronic inflammation, because all of these factors will determine what the current state of your socket is, will determine what your treatment or how difficult your treatment is going to be. So it's important to, give all of these points in the negative history. All of the things that I have said about all of these cases, it's important to make sure that you're saying them as a part of a negative history so that your examiner knows that, yes, you've thought of all of these things. And of course, trauma, we want to, ask whether there was any trauma. So when you're doing the examination, what you're going to look at, one of the common things that we see post enucleation is the post enucleation socket syndrome, the PES. And what we see commonly in those cases is a superior sulcus deformity. Like if you see in this case, his superior sulcus is very deep, and there's not, it does not have that fullness that the normal eye has. The other thing we see in these cases is lower lid shelving, which essentially means that the lower lid is not firmly up against the implant. It's kind of falling down. There's shelving of the lower lid, which means it's kind of like an ectropion. Now, the problem with that is that if the lower lid is not snugly resting against the implant, there's not a good enough fitting for the prosthesis. So the prosthesis tends to fall out. in these cases where the lower lid is kind of, in an ectropion-like state. The other thing that you can see in the post-enucleation socket syndrome is also enophthalmos and sometimes entropion of the upper eyelid. So these are the things you have to look at. You have to comment on the state of the upper eyelid, the lower eyelid, if there is any gross enophthalmos compared to the other side. Now, when it comes to examination, we want to look at the area of the socket and the volume of the socket. Now, I found this on the internet. I think this is something called a fornicometer, or just this little device that they've made to measure the depth of the fornix. It's very important to measure the depth of the fornix because the depth of the fornix is going to determine the size of the ocular prosthesis. And essentially, it's your fornix. The fornix is a space between the eyelid and the eyeball, which retains the ocular prosthesis, the eyeball or the implant. So when we don't have this during our examinations, but what you can do is you can instill a drop of paracaine. You can take a lacrimal probe, and then just put it down in the fornix, and you can measure what the depth of the fornix is. So it's important to know you can write it down what your superior and inferior fornix depth is. Now, one way to measure the volume of the socket is, again, you put a drop of paracaine, anesthetize the eye, and then taking some saline in a 3 ml or a 5 ml syringe, drop by drop, you fill up the socket. This is without the prosthesis. And as the first drop falls out, that much is the volume. So when you have the socket, you kind of just putting, 1 drop each of saline. And then if after 1 ml or 2 ml, whatever it is, there is an overflow of the saline, that the volume is 2 ml because that's how much saline is being retained in the socket. Now, these are all not really used for practical considerations, but examiners like to know that you know how to measure the volume. So they will, even if they're not expecting you to actually demonstrate it, they do expect you to know how we can measure the volume and the area of the socket. The other important thing that you have to comment on is the conjunctiva. You have to comment whether it's dry or wet, whether there is any discharge in the conjunctiva. You have to look at the movement of the fornices. You have to look at whether there's any bony contracture. Now, by movement, I mean you have to make the patient look up, down, left, and right and see if the fornix is moving. Sometimes if there are a lot of adhesions between the conjunctiva and the eyelid, then the movement is not going to be as great. And that's one of the causes of a contracted socket. So that's one of the things that you have to look at. So you want to look at all of these things without the prosthesis. You also want to look at the movement with the prosthesis. Like you can see in this case, there is lower lid shelving and there is almost minimal movement of the prosthesis. And when you ask him to close the eye, his eye cannot close completely. So this is obviously a socket which is not great. The prosthesis is not fitting well. So we need to do something to reconstruct it. Now, the other thing that examiners like you to mention is the classification, is talking about the severity of the contracted socket. One of the more common classification methods is the Gopal Krishna. You can take a screenshot of this. It's from grade 0 to grade 5. What we use commonly and what is a more common, more practical way of assessing socket contraction is this. I don't think it is named. Maybe it has a name and I'm missing it. But this is quite simple. It talks about mild, moderate, severe, and malignant. Mild is where only one fornix is contracted. Moderate is where there is a decrease in the area, but the volume is, intact. Severe is where there is a decrease in the area and the volume. And malignant is, post-radiation sockets where there is a bony contracture as well. Now, this is very easy for your treatment algorithm because for mild cases, you just do a symblepharon release, add an AMG. For moderate, you would like to do an AMG or a mucous membrane graft, depending on how much the area contraction is. For severe cases where you want to do an area plus volume replenishment, you can do either a dermis fat graft or you can put in an implant and do an MMG. And for malignant, of course, where there's a bony contraction, you would require more extensive methods. So again, even in cases of contracted socket, once your examination part is over, the discussion usually goes on to the treatment. And so you need to know what are the various ways of treating the contracted socket. But before that, it's important to know how contracted your socket is. So when you come to the diagnosis, you have to mention how severe it is, what grade it is. You can either mention grade 0, 1, 2, 3, 4, or you can, say that there is an area contracture or a volume contracture. You have to obviously mention whether it's an ophthalmic or an anophthalmic socket, whether conjunctiva is wet or dry. Again, because once you've made this diagnosis, this will then lead the viva in the direction of the management, where we talk about whether you're going to do an amniotic membrane graft or a mucous membrane graft. If there's volume loss, like I said, you might do a dermis fat graft. So all of those things. So hopefully, this was a bit of a bird's eye view, but I think what I want to emphasize in this is that the examiner is not expecting you to know that, this particular case is rhabdomyosarcoma and it requires chemotherapy followed by surgery for the treatment. No, they want to know that if a child comes to you with proptosis in your OPD, do you know that what are the questions you have to ask? So are you doing your history taking correctly? Are you being able to examine? Are you being able to figure out whether there's axial, abaxial proptosis, whether it's a cystic mass or a firm mass? If you have a differential diagnosis after that, any specific tests that you need to do, are you doing those? Like in a case of ptosis, you have to ask about diurnal variation. If the patient is saying that there is a diurnal variation, are you doing an ISPAC test in your OPD? And then on the basis of that, have you reached a differential diagnosis? Once you've reached a differential diagnosis, what are the other tests you're going to do, to confirm your diagnosis? For instance, radiology, a CT scan, MRI scan for your proptosis cases. For myasthenia, you might do an anti-ACH receptor antibody. For thyroid cases, you might do your whole thyroid panel and thyroid receptor antibodies. So for your lid tumors, you have to do a PET scan to look for metastasis. You have to rule out immunocompromised states. So, once you reach this point, you've already cleared 70-80% of your viva and you're passing. The last 20-30% management is for you to get your distinction. But I think for everyone, in order to pass, everyone should be getting at least this much, right? And once you've gotten here, once you've got your differential diagnosis, then of course there's specific treatments for different situations, which your viva moves on to the next level. So I hope this was helpful, and I would be glad to answer any questions if you have anything.
Yes, thank you so much, ma'am, for such a well-articulated session for all of us here. We have some questions and from our PGs here. I'll try to go from the basic ones. From the history point of view, ma'am, what are the key history points which should be noted to differentiate amongst inflammatory, neoplastic, and vascular orbital lesions?
So again, inflammatory, and that's a good question, because when we talk about inflammation, you will usually have some other signs of inflammation. So you will have pain, you might have fever, you might have pain during movement of the eye. So that is more indicative of anything inflammatory. If it's vascular, if it's a venolymphatic malformation, then there is typical increase in the tumors with upper respiratory tract infection. So you have to ask about any change with upper respiratory tract infections, any change with Valsalva. They will not answer Valsalva, but you can say if there's any change in the pressure or anything, do you feel that, or if there's any change with the position. I was trying to show, if you put the head down,
Right,
in cases
right.
of varices, you will have like an increase in size. So you have to ask that. And
Okay.
malignancy onset, it is more of an acute onset, usually less than 6 months. If your mass is progressing, you know that it is malignant. If, again, you want to ask about periocular sensations, pain is associated with malignancies in a lot of cases. And if there's any other lumps, if there's any weight loss, fever, lower back pain, other
Loss of
questions.
appetite.
The loss of
Yeah.
appetite, metastasis. All
Okay.
right.
Ma'am, another question that has been asked is tips for cranial nerve examination specific to orbital pathology. I mean,
So you want to, so basically, when we're looking at this, a lot of it is orbital pathology. So the two main, we obviously want to look at the optic nerve. and that you can see with your visual acuity, with your RAPD, color vision. You want to look at the third nerve. When you're looking at the third nerve, again, you want to look at the movements of the eye, and you want to look at the pupil if it's a third nerve involvement. Then I think more important is the fifth nerve, because your fifth nerve has this whole sensory supply over here, which is very commonly affected. So whenever you ask to examine these cases for the fifth nerve, what you ask the patient to do is you ask them to close their eyes, and then you kind of rub your finger here and then on the other side, and you ask them, if it is 100% on normal side, how much is it on the other side? Is it 60%? Is it 50%? That is one way of asking. I think that's it. And sometimes the seventh nerve is also involved. So if you have an associated facial nerve palsy, then of course you ask them to, smile and raise their brows and all of that. I think that's about it. Is there anything you think I missed in?
I think 2, 3. Yeah, I think it
And
covers.
3 and 6, of course, extraocular movement comes together. So that's most of it. Sometimes if you have meningiomas that, if you have gradinigos or something that might be affecting the eye and the ear both, then you have eighth nerve involvement as well. So which is why you carry the tuning fork. We used to do that
Okay.
during our exams. So that's one of the things, for extra marks.
Right. Ma'am, thyroid eye disease is a very common long case in a lot of institutes. So it has this huge list of signs which is written in most of the books. So what are the mandatory signs which have to be mentioned? If if somebody is not able to cover the entire list.
So I think you should start off in a systematic fashion. You start off with visual acuity. Then you look at the pupils. Once you've done that, you look at the palpebral height. So you look at the MRD1, MRD2. That will also give you an idea of the eyelid retraction. So we're looking at the eyelid. Once you've done MRD1, MRD2, you look at lag of thalamus, whether the eye is closing or not. You look at lid lag, when looking down. You look at ocular movements. There's a couple of them associated with ocular movements. I think those are the more important ones, because those are the ones that have functional implications. So, and this is in general a principle. Unfortunately, in our Indian system, there's a big, we really like to
Name,
say a lot of theoretical,
names.
but if given a choice, if you have all these signs, look at what the functional signs are. Like if there is an inability to converge, right? That's something that's going to cause double vision. So you look at the extraocular vision, you have to do, extraocular movements, or the eyelid retraction that will cause lag of thalamus, that will cause keratopathy. So those are the things you have to mention, because staring look, the look does not mean anything, but eyelid retraction, that is important. So I would actually not mention named things during my examination. If an examiner asks you what is the name of this sign, that's a different thing. But if you already start naming all these things during your findings, when you're seeing them, like Dalrymple sign and all of that, then you'll get into trouble, because then they'll ask you some different signs name that you wouldn't have heard of, and you'll get yourself into trouble. So just mention your examination. Don't do very fancy things. Start with basic. Let the examiner ask you. I think let them come to you. Mention your negative thing, but try to not be super over enthusiastic, because then you will have foot and mouth syndrome. So let them also ask you something.
I
But yeah.
think that was a great tip because most PGs are worried about memorizing that whole named list because it has this exhaustive list of name signs.
Yeah, I mean, the examiners also don't remember everything.
Okay. Okay.
So I feel if your examination is on point, even if you've remembered those 15 things, but if you're missing out something major in your examination, that's more of a problem than remembering those things, right? So try to think of it like that.
And ma'am, in a case of thyroid eye disease, is clinical activity score sufficient, or we have to mention about UGOGO score or that as well?
So
Both.
CAS, you definitely should. You go, so there is no specs, visa, I think.
Yeah,
Right?
visa and
Visa
UGOGO
and
both.
yeah.
Yeah.
Uh, you know, CAS for sure. But if you get a thyroid eye disease case, you will have the time. So, make sure that you write the no specs and visa you don't have to get the CAS is something that you have to get, right? Because that's something that most examiners know also. But at least know these classifications, know that these are the names, and then we do it. And then, of course, if you do get a case of thyroid eye disease, then knowing these classifications, but also knowing what is the treatment protocol. You need to know what the go treatment protocol is, that for the first 6 weeks, you want to give them 500 milligrams of IV methylpred, and then next 6 weeks, you'll give them 250. There's a great go consensus article is there. So now you have chat GPT, you can give them the PDF and just ask it to summarize. So you have that one slide for management of thyroid eye disease, and then just keep it with you. If you get a case, everyone gets the time to read in between the viva. So you can always, sort of just brush it up at that time.
Okay. Ma'am, in case of ptosis, in case a BPS case is given, what are the additional measurements that need to be taken other than the basic ptosis pro forma measurements?
That's a good question. So you obviously have to mention epicanthus, because there is epicanthus inversus. So the question that comes after that is, what are the different types of epicanthus? There are 4 different types. You can find it. So you should know that. Then you have to measure the telecanthus. So in that case, you want to measure the intracanthal distance. उसमें फिर question आ जाता है कि what is telecanthus, what is exorbitism, you divide the interpupillary distance by half. That should be your normal intercanthal distance, right? If I measure this distance is half of this distance. But in BPS cases, this is going to be a little more. So intercanthal distance, interpupillary distance, and just again, these questions come in exorbitism and all of that. Dr. Praful has a great book which has all of these viva questions also, in specifically related to each case. It's
Ophthalmology Clinics.
Yes. We are being sponsored by ophthalmology. We were curated by Ophthalmology Clinics. So plugging in that in the book. But it's a good book. It's a good book.
Right.
You have for specific questions, you'll have all these answers. So it's good to know. Yeah.
Very high-ended. Okay. This is a very basic question that I think most of us should know. I mean, it would help all of us. How would we decide between CT and MRI in the different cases of orbit that we can come across?
So some of the considerations are, first of all, if it's a soft, like if it's you want to know a soft tissue delineation, MRI scan is always better. So this is how you give your answer. Ma'am, if I'm wanting to, ma'am or sir, whoever, if I want to get a good soft tissue delineation, I would ideally like to get an MRI scan, because a contrast enhanced MRI scan will give me a better idea about the internal consistency of whatever the mass is. But if I'm looking to operate, I would additionally like to have a CT scan also, because that will give me the bony margins. If I don't have the budget, if I'm in a low socioeconomic region, because that's one very common question, कि तुम गांव में बैठे हो, गांव में थोड़ी MRI कराओगे, So if I don't have the facilities for an MRI, I would like to go for a CT. And additionally, if I'm looking to operate, I would additionally like to have a CT as well, because a CT is going to give me the bony the bony structure of the orbit, and I need to have that if I'm operating. But if I don't have an MRI, CT is what I would like to go with. Or the other thing, I think I mentioned this also, that if it's a bony structure, if you're expecting that maybe it's something like fibrous dysplasia or something, which is specifically not a soft tissue mass, it's a bony mass, then in those cases, you would like to go for a CT scan. Yeah.
In continuation to the previous question, ma'am, what details should be exactly known regarding radiology in proptosis? I think in long cases, we might not get the scan, but maybe they can be asked in Viva, what would you look for in your MRI or CT specifically?
Yeah, so you want to, of course, have all the 3 cuts. You want to have axial, coronal, sagittal. You want to know whether the scan is with contrast or without contrast. You would like to see whether the mass is intraconal or extraconal, whether it's within the cone of the muscles or whether it's outside. If it's outside, which quadrant it is in. Essentially, you're just confirming everything that you're checking with your examination. Which quadrant is it in? Is it in the superior, inferior, whatever, medial, lateral? Then once you've done that, then you would like to see the internal consistency, whether there is any contrast enhancement or not, whether there is any fluid level. Fluid levels are very typical of venolymphatic malformations. So if anyone says fluid, then you know that we're talking about venolymphatic malformations. If there is any extension to any surrounding structures, if it is going into the nasal cavity, if it is causing destruction of the surrounding structures, this is an important point, because if it's malignant or if it's malignant like, because of course you have malignancies, you have malignant tumors, but conditions like mucormycosis also behave malignantly. So they will destroy all of the adjoining structures and progress very rapidly. So it's important to see the integrity of the surrounding structures. What else? I think if you've done this much, it's pretty good at PG level. I don't know,
Yeah,
is
I
there
guess.
anything else that you can think of adding?
I think it's covered most of it, ma'am. The critical structures, the extent, the location. I
Because
think most of it is
then we
covered.
move
Yeah.
on to higher stuff, then we talk
Yeah.
about diffusion-weighted imaging and all of that,
Yeah.
which I think that's too much. That's out of the
Okay.
scope of a
True.
postgraduate. Yeah, so these are the
Yes.
things you need to know.
Ma'am, another
But just before that, the most important thing is if you're given scan, sabse pehle you should know what is an MRI and what is a CT.
Yeah.
right.
Don't call a
True.
CT an MRI scan. So if you're seeing more bone, then you know that it's a CT. So this is something I can't teach you, but very basic thing. Don't mess that up. And after
True.
that, move on with your Viva. Yeah.
Ma'am, another very confusing point for most PGs is in after everything, if they've reached a conclusion of it being a suspected inflammatory orbital disease or an infective orbital disease, so what lab workup should be suggested? Because there are a huge list of investigations that can be ordered for this. So what should we precisely answer for this?
So if you're expecting that this could be something infective, then then you want to do an infective workup where, of course, you'll start with a con swab. So one is if you're doing a biopsy, that is a different thing. Both things, if you're taking a biopsy, then that's one thing. But if you're not doing a biopsy, like it's like how you treat your patients of cellulitis. I'm sure every hospital gets cellulitis patients. And what is the basic workup you're doing there? You're sending a con swab, you're sending a pus culture if you have that, you're sending a blood culture, you're sending your CBC, RFT, LFT, all of those cases, urine culture. So all of those things from the point of view of an infective, this thing. If there is a frank endophthalmitis, maybe you might want to do a vitreous biopsy or something. When it comes to an inflammatory thing, yes, there's a huge workup that you have to do. You have to do essentially, basically, your inflammatory markers. You're looking at CBC, ESR, CRP. Then we move on to specific things. So again, for all of these things, you can't just be blindly ordering. You have to know
Exactly.
what you're ordering what for. So if you're thinking about, say, sarcoidosis, which is very common, then you would look at serum ACE levels, right? That's one of the things. And for sarcoidosis, you also have to look at the retina. You can have candle wax drippings and all of that. Then if you have IgG4, which is again one of the common things, then you would look at serum IgG4. Then, of course, you have HLA B27. So you'll have to basically look at the list of causes of inflammatory orbital disease, what are the tests used for that, and then make a list of that, because it's tough to cover all of these things. But just go to
Yeah.
whatever your chapter of inflammatory orbital disease is, and then look at what are the things are, then what are the serological markers that we use for every specific thing. Like you have Bechet's also, then you have, for Bechet's you have HLA-B51, but I'm sure I'll miss out a lot of things. So you have to
Right.
make a list of 4 or 5 top causes of inflammatory orbital disease, and then what are the things we do for
Okay.
serology for them, and make a list, and that's what your thing is going to be.
Ma'am, in interest of time, I'll be taking up another last question. What are the indications for biopsy in a case of proptosis or orbit pathology?
uh Good question. See, so if it's a well circumscribed mass, so there's two things. One is if there's a mass, the other if it's a non-specific orbital inflammation, inflammatory orbital disease. In cases of inflammatory orbital disease, also there are two schools of thought. Some people say that you start them on a course of steroids, but I think the ideal thing to say is that ideally we would like to do an incision biopsy, see what the exact pathology is, and then start on treatment. This is for inflammatory disease or infective disease cases where there is no specific orbital mass. If there is a specific orbital mass, if it is well circumscribed, like like a lacrimal gland tumor or a cavernous hemangioma, then you would like to do an excision biopsy. In these cases, you would like to take the whole mass out. If you feel it's a malignancy, or if it's something which is, traversing two compartments, orbit and this thing, in those cases you would like to do an incision biopsy first, see what the thing is, or like rhabdomyosarcoma, where it's a malignancy, because the treatment for rhabdomyosarcoma is not surgery, it's chemotherapy, or lymphoma, so you do an incision biopsy and then you move on to the treatment. So there is always an indication for biopsy in most cases of proptosis. Question is whether it should be incision or excision, or if the patient is not willing, do we do an FNA? That's the thing. I think that's the real question, because you would always typically want to do a biopsy in 99% of these cases.
Thank you so much, ma'am, for this very well put session. I'm sure a lot of PGs are going to benefit from this because plasty puzzles a lot of people, I believe. And
Past is also the most interesting because
yeah, I agree.
yeah, but we're all plastic people, so we're all biased also.
Could be. To all our viewers, our next session would be on 16th of May on instruments by Dr. Pranita Sahai and Dr. Devesh Kumawat. We'll see you then, same place, same time. Thank you so much, ma'am.
Thank you.
Thank you.